Hi, so welcome to another episode of Behind the Knife. We're going to go this kind of combined audio visual one. So for those of you who are listening, great. We're going to try to walk you through it. And for those of you on the YouTube channel, welcome and thanks for joining us. It's Scott and Patrick obviously here. And Patrick, we're going to talk about something today that is a very, very difficult and encompassing and such a varied topic. And that's dealing with and defining actually anastomotic leaks. And so kind of with that, can you set the stage for us? This is something that is obviously very, very difficult on patients and extremely difficult also on surgeons, something that we've all experienced. One of my mentors told me once, if you don't have a leak, you're probably not operating, but it's something that all of us across the board strive to minimize to the highest degree possible. So set the stage for us.
Oh man, leaks stink. No one wants a leak, and even sometimes if you do it perfect, the perfect patient, you got perfect anatomy, everything's technically excellent. Sometimes they leak, and managing those leaks can be challenging because they come in a whole lot of different flavors. And I can't tell you how many M&Ms you've been to where you have the resident, myself, you're presenting, you say, here's this leak, and you show some data about tension and blood supply and steroids and these other things, and you try to rationalize what happened or what you could do differently. And sometimes there's not a great answer for that, and that's really frustrating because the overall incidence of leaks is 2 to 7%, and that's with experienced surgeons. And the lowest leak rate is for ileocolic anastomoses, which are about 1 to 3%, and the higher is for those coloanal, those low anastomoses, which can be even with experienced surgeons 10 to 20%, which is high. And most leaks appear 5 to 7 days post-operatively, but they can go even farther. Dr. Steele, you've probably seen plenty of leaks that come back to you in clinic. You're out 15, 30 days even until you see these leaks again.
Yeah, I wouldn't necessarily say that I see plenty of leaks, as all the surgeons would say we'd have that. But no, there's no question. As a matter of fact, for those of you who like to go to some research out there, I always say take a look on PubMed and look up Neil Hyman's paper when he was at Vermont and for colorectal anastomotic leaks. And in that particular one, it was outwards about two weeks out was the average one. And that's probably a lot longer than a lot of the listeners out there or the viewers would suggest.
Yeah, and how do you define leaks? Because if you look at, because I'm giving you all these percentages of leaks, but those come from a variety of different papers. So how do you clinically define leaks? Because you have clinical signs, radiographic finds, you have intraoperative findings. What is the definition? Is there one?
Yeah, I think that's probably one of the most interesting aspects of leaks. And I think we've all been in that situation where you've seen somebody say, oh, really wasn't a leak. That was just an inflammatory reaction. Or, oh, that's just a few air bubbles around the anastomosis. Or is it something that's in a drain? Is it a really leakage of contrast? And there has been many, many, which we'll go into a little bit later, kind of consensus statements or Delphi methods to take a look at how we define leaks. And I think my take home has always been, you kind of know a leak when you see one, but it's really when you get into the definition of what defines a leak, there is a lot of variability in the lecture, which is why you see a lot of these percentages a little bit all over the map.
Yeah. And so let's before we dive in, because this is all about decision making, how you manage these anastomotic leaks. These leaks can come in all different types of flavors. Let's talk about risk factors briefly, though. So first, let's talk about extraperitoneal anastomoses, and then we'll talk about intraperitoneal anastomoses. So starting with extraperitoneal anastomoses, there's a few major risk factors. One would be the distance of the anastomosis from the anal verge. And I think the main number to remember is within 5 centimeters of the anal verge, your risk of leak goes up much higher. In addition to that, male gender, actually. And Dr. Steele, and you can tell us more about this, but is it the male anatomy, the narrow pelvis, that we think that causes that higher later rates of leak?
Yeah, absolutely. I think that, again, a lot of these studies are independent risk factors. So we probably know that there's a little bit more to it. For example, you have oftentimes, especially in the US, a large body habitus with an android pelvis that's very narrow, and then you're bringing down that left colon for a low anastomosis. And again, as you get down there, we're thinking about tension, blood supply, narrow pelvis, lack of collateralization. All these things probably come a little bit together, and there's probably something. So I don't think it's necessarily saying at least that I know of, and to say this is why a male has a worse one. We do know that there's anatomical differences between the two, such as what you just mentioned in terms of that. And then we do know that in certain cases, when you combine tumors with radiation, with low-lying anastomosis, a male pelvis, a certain BMI, and a smoker, and prior radiation therapy, now you're talking about somebody that, you better be able to think, what are we going to do to defer that leak?
Right, right. And one of the last things you can read about for extraperitoneal anastomosis is obesity. And there, if you dig deep on that, that's actually a totally mixed bag. Some studies show that it may increase risk. Some studies don't. So how about for intraperitoneal anastomotic leak? One of the main findings from a pretty large review was that an ASA score of 3 or 4 puts you higher risk of leak. That makes sense. These are sicker patients, not as healthy. They're not going to heal as well. Emergency surgery is another risk. Also makes sense. These patients are coming to you, coming in hot usually, and you oftentimes are not operating in the most ideal settings there. How about prolonged operative time? This is an interesting one. The cutoff that is most commonly used in the papers is 4 hours. Dr. Steele, what do you have anything to say about that?
Yeah, so there's no question. It's probably, you say to yourself, what is going on that you're going to have a prolonged operating time? And in many cases, that may correspond with a more difficult surgery. It may correspond with essentially higher blood loss, more complex, patient anatomy, for example. That's where kind of BMI and everything goes together. And I think that, again, another one of these things, and a lot of these papers, remember, are retrospective reviews where you get a positive p-value or you get an odds ratio that's greater than 1. And so, we do know that a lot of these things go hand in hand. One of the more interesting things is for intraperitoneal leaks is specifically to bowel. And again, we're kind of focusing right now on some of the colorectal anastomosis or the colon. We're not really focused on some of the upper GI. And I want to make sure that we clear that for our viewers and our listeners today. But the ileocolonic anastomosis, that is one that is actually an intraperitoneal anastomosis that is associated with a higher one. And we do know that small bowel heals a small bowel very well, right? Think about what the leak rate is associated with a diverting loop ileostomy takedown when you're kind of going to yourself. It's not 0 by any means. We've had leaks associated with that, but it's not necessarily the higher one. And then you take that small bowel and you attach it to the rectum for somebody that's had a subtotal colectomy, and those tend to be a little bit higher risk. And again, is this blood supply? It tends not to be tension. Is there something that's going on a molecular level that's having problems? And again, one of the things that we're not going to have time to touch on tonight is something that many of you will have read about and makes in many of the leak symposiums that we put on, and that's what is essentially the biobacteria, if you will, of that particular patient. And we've talked about things that's metalloproteinases and what is the what is the makeup of the GI gut, and how does that play into a leak? And I think that is obviously one of the more emerging, led by people such as John Alberti out of the University of Chicago, who has done some unbelievably, incredibly valuable work on this. And so I think as we get into that a little bit more, we may find some of the other aspects that are contributing to leak.
Yeah. Rattle off a few more. You mentioned radiation. Steroids are associated, tend to be associated with higher risk of leaking. Nutrition, poor nutrition, depending on what you read. But how about a protective stoma?
Yeah, so
because that make you say, well, I have a diverting loop. I'm safe. How does that play in?
So that's one of the things we're going to cover in our cases tonight. And so I think that's important. So when we take a look at this oftentimes goes into the fact of how do we define leaks? Are we talking about an asymptomatic, clinically asymptomatic, or minimal symptoms, not septic for sure, leak, or a radiographic leak versus one that you're trying to be able to say that they are overtly clinically septic? And so studies out there, like most studies, you could find some that suggest that it is protective of a leak, and others that say it is actually not. What it is protective of is making the patient septic from the manifestations of leak, because the vast majority of the stool for a diverting loop ileostomy, for example, in a low colorectal anastomosis or a coloanal anastomosis, is essentially being diverted away, so they're not manifesting in a septic state.
Exactly. Okay, 2 last ones I'm going to ask you about because the data is pretty mixed. One would be the use of NSAIDs postoperatively. What's your take on that?
Yeah, that's a great thing. And you're right on the head. And when I was in Washington State, Scope did a collaborative on this, the Surgical Consortium out there with many different Pacific Northwest hospitals that, had a great paper on this. And what I would say is that it's intriguing. And, there are some concerns about the effects of NSAIDs and, potentially some of the at the enzymatic level and what's happening there that is contributing to a leak. I can tell you that probably as many papers as you can find in that is as many papers as you can find that it's not. What I would tell you is that that might be a piece of the pie, maybe not the strongest piece of the pie. And I do know, because I've had these conversations at symposiums where people say, listen, I have Toradol as a part of my non-narcotic pathway and enhanced recovery pathway, and we don't have an increased leak rate. And so I don't think we know the true answer behind this. What I would say to you is that if you have somebody that you are using NSAIDs or debating using NSAIDs on, and they have some other risk factors, that might be something that you might say, do I want to be able to use this? Is it something that's going to push a little bit over the edge?
Right. And so then the last question I had for you, what was it? Mechanical bowel prep. And well, let's separate it out to antibiotics and mechanical bowel prep.
Yeah, I think so. There's a lot of really great papers out there, and this is something that you've definitely can see Cochrane reviews. You can definitely see many systematic analyses that would say that mechanical bowel prep is associated with an increased leak, and you can also find other ones that it's not. And in some of these cases, it's important when you read this literature to make sure that when you delve into it, are you talking about superficial surgical site infection, organ space infection, leak? What are you talking about? Because some of those may vary. What I would tell you is that in general, if you're talking about the risk, because bowel prep is one of these things that's a pendulum, right? They never did it. Then with the Nichols-Condon prep back in the 70s, all of a sudden, boom, which is very interesting. I encourage all of our viewers to go back and look at that original paper. One of the original papers, it has, I think, only 20 patients in it, a very low number, one of a classic one. And then again, and all of a sudden everybody was bowel prepping. And then all of a sudden we're talking about adding oral antibiotics to the bowel prep. I think it was pretty clear. And a lot of this was a very nice paper done out of the quality collaboration out of Michigan several years ago, talking a little bit about how the bowel prep itself, when you add antibiotics versus a mechanical bowel prep alone, is probably associated with no increased risk of leak. So if you're going to be a bowel prepper, probably best that you're adding oral antibiotics to that in addition for surgical site infection to make sure that we're adding that IV antibiotics within 1 hour of the incision. And that a mechanical bowel prep alone is probably not something that is as valuable as having that mechanical bowel prep plus the oral antibiotics. There is some data that is out there that talks about oral antibiotics alone in the absence of a mechanical bowel prep. And again, there's not a lot of large scale things. There's a couple of NISQUIP papers that have looked at a small subsection compared to the larger for those who've had a mechanical bowel prep or a mechanical bowel prep plus antibiotics. And so where that data ultimately pans out in remains to be seen.
What do you do for your patients for elective coloanal?
Yeah, so we do a mechanical bowel prep with oral antibiotics and then IV antibiotics within an hour of the incision.
Excellent. All right, so let's jump into some of this decision making. We have some amazing video here, and this has been a topic that you, Dr. Steele, have talked about in numerous different conferences and organizations, and always gets a lot of feedback and lots of attention. Again, going back to this frustration behind leaks. So let's jump in.
Yeah, so Patrick, I'm going to put you on the spot on some of these cases. And again, I think that what's very interesting is this is something that for all of us surgeons or to-be surgeons out there, or even any caregiver or a patient that's watching this is something that can hit home. And I think the take-home point is something that you mentioned earlier is that A, all leaks can't be defined the same. B, all leaks can't be treated the same. You got to work your way through it. And that ultimately our ultimate goal is to make sure that we try to minimize this as much as possible, because the best leak is the one that never occurs. And so with that, I wanted to grab a couple of cases out there that would kind of take a look and say, is this a leak? What do you do? And just to show the variability in this. So, and first, one of the things that we see is right here. And so for all of our listeners out there and not our viewers, what I'm showing is a picture, a classic chest x-ray with that free air associated underneath the right hemidiaphragm. So you get a call, Patient is having belly pain on post-op day 4 after an operation, and all of a sudden they got free air there. So Patrick, in your mind, how do you think about the setting of, and again, this is not spontaneous, this is in the post-operative setting. How do you think about free air, especially in the post-operative setting underneath the diaphragm?
Well, you had to open that belly at some point, so some air gets entrained during surgery, and typically that air goes away within the first 4 to 5 days from my typical experience. And the question then is, how does that patient look clinically, right? You mentioned it. If they're having belly pain, if this is a change from where they're at a baseline, change in vital signs, fevers, white count, etc., well, that air underneath the diaphragm likely means something, and you should really be thinking about the next steps in terms of your workup.
Absolutely. And I think that's a critical point, is to always remember that when you're talking about somebody that has free air underneath the diaphragm, you got to put it in the clinical context of what you're seeing, because many people will say, again, we're not talking about a patient that has not undergone any surgery, but we do know even with those patients, for example, perforated diverticulitis, which we've done our clinical challenges on in the past, and I encourage all of our viewers and our listeners to go back to that particular episode. But free air might be something that doesn't need an operation at all. As we start to go out a little bit more, was this open surgery? Was it a laparoscopy? Should it be gone by now? But you really have to put it in the clinical context, and so that's critically important and a great point from right there.
And that can be tricky, like I said, around that. You start getting 3, 4, 5, 6 days out. Should that air be there? How much air is okay? And again, it does matter clinically. So what that patient looks like. So what do we got here?
Absolutely. So now I'm going to give you a little bit different scenario. So now we talked about all the variability in terms of when potentially leaks could happen. So now you're confronted with a situation where somebody's a little less than 2 weeks out. In this case, postoperative day number 13 from a sigmoid colon operation with a colorectal anastomosis. They presented with belly pain. They come in either to your emergency room in this particular case. They have fever. There's a little bit of urinary urgency, but they had a negative urinalysis, and the white blood cell count is about 12,000. For this particular situation, they're a little bit tacky, they're a little bit distended, their belly's a little bit bloated, and they get a CAT scan. So Patrick, walk me through what you see on this particular CAT scan.
Yeah, so it's nicely marked for me there, so I can see it. You're up to a 6 centimeter errant, a fluid, or at least some type of a free extra GI type content there. And I can't, without the additional slides, I'm presuming that's near or next to our anastomosis. Yes.
Yep, absolutely.
Great. And so a number of things to consider here. This patient, you said, is not terribly toxic, but not feeling great either. They have that white count you mentioned. And so the next question is, how do you manage them? For anything over around 3 centimeters or so, and we did talk about this in the prior diverticulitis episode, you want to try to drain it if possible. But you need to have a window to drain, whether it's percutaneous or transrectal. You need to have a window to get there. And so if drainable, I'd want to drain it. In addition to that, broad spectrum antibiotics, and then keep a close eye on that patient.
Yeah, so to dig into that a little bit deeper, I think the first thing we always start with as medical providers is, what is the clinical state of the patient? I tell a lot of my trainees out there is that the first question you should always ask yourself whenever you have any sort of a consult is the patient sick or not? Because if they're really sick, it's going to be something that is going to drive what you do. And if they're stable, you got a little bit more time to work them up. Is this somebody that gets this CAT scan? Do they need another study to make sure, with contrast or rectal contrast or gastric anatomy or anything, or is it not needed? And in this case, you see a 6 centimeter by a 5 centimeter abscess as delineated on this cross-sectional imaging. And then we're talking to our interventional colleagues. So Patrick, one of the questions that comes up all the time is if you do have an abscess, which oftentimes is something with a little bit lower, not necessarily from somebody who's overtly septic, has had an anastomotic leak, and they're really kind of either that is supposed to wash out or take back for that leak, or they come in that place and they may have these multiple small little abscesses everywhere. But this is a defined abscess, oftentimes with a little bit lower leak in here. How do you decide whether or not to get your interventional colleagues involved? And is there kind of certain type of abscesses that that you may say, yeah, they only need antibiotics alone, and let's just sit tight?
Yeah, I think going back to that size criteria does matter. A smaller abscess is something that you can often treat through, especially if that patient is non-toxic. I think that's the first and easiest way to remember. And again, 3 centimeters is roughly something you can put in your head there. The second is related to the risk too, and where that of accessing that abscess. I think nowadays, you can have a good look at the CT scan and understand for yourself if there's going to be a good window to get into the drain. If we're able to drain that abscess safely, I'd want it drained. The abscesses here, and we might get into this a little bit, are, depending on if we think there's an active abscess or is this or an active leak, excuse me, or is this an older abscess too? Is this something that was a leak that happened 4, 5, 6 days ago, and this is the residual of that? There are some different ways you mentioned that maybe we could work that patient up potentially with contrast, et cetera, where we could ascertain whether that's an active leak as well. And also, you can also trial that patient, get them hydrated, get them on some IV antibiotics, get them in the hospital, and see how they're doing. If they're doing clinically well, that's a good sign that you may not have to embark on a drain placement.
Yeah, I think one of the things that also throws a little bit of a red herring in here is consider the timing out. As we all know, is that as you start to get into this 13, 14, 15-day period when things get rather stuck in the belly, if you're going to take that person back. So it might not necessarily, even if you have to take them back, it might not be the most pleasant type of operation with a lot of really dense adhesions and a very difficult ongoing, and oftentimes relates into you taking that patient, and finding yourself in a difficult situation where enterotomies are made, or you're forced to take down the anastomosis and, winding up with a colostomy or anything. So to be able to, in a stable patient, to just exactly you're saying, resuscitate, be able to try to get a drain, IV antibiotics, NPO, and do the basics in that stable patient is clearly something that is important first step. Okay, so here we go. Here's a little bit of a different type of scenario. So now this is a little bit lower. We don't have that colorectal anastomosis. This is somebody in the cross-sectional imaging. If you walk us through this is a little bit following a low anterior resection. We're a little bit lower in the pelvis. Our anastomosis height is maybe around that 5 centimeters. And the bladder is filled up in front. You can see a little bit of stool in there, and you see about a 5 centimeter by 4 centimeter fluid collection that's actually pushing the rectum to the left. How is this different?
Yeah, so this is a larger collection, number one. Number two, there's more extensive involvement in the pelvis. And number three, it's very clearly easily accessible based on this single shot that we have, this single axial image from the CT scan.
So so this just wants to highlight the fact that when you're talking about these lower type of abscesses, our interventional radiology colleagues will oftentimes talk about, do you go transgluteal? In this particular case, there's a nice window to be able to go there. Obviously, we're concerned always that you may wind up with an extrasphincteric or a very complex fistula out of this. Is it something that you can drain into the rectum itself? Is it something to be able to take a look at your anastomosis? And in many cases, what I would say here is that, if this is somebody who's a fairly fresh post-op, this might involve going back to the operating room for a good examination under anesthesia, flexible sigmoidoscopy, a very nice look and see, is your anastomosis disrupted? Is this something that you can put a drain in through your anastomosis and drain this transrectally so the patient doesn't have, the potential chance to have that extrasphincteric fistula that might occur with this? And so we oftentimes don't think about, and one of the reasons that I wanted to bring this particular one in is that you have a couple of different scenarios with abscesses. On one scenario on abscesses, you have somebody that's really sick and they're not doing well, and doesn't matter what it shows, you got to go back to the operating room. Then you have a stable patient and it's intraperitoneal. One of the things that you led off with, Patrick, is talking about the difference between intraperitoneal and extraperitoneal.
Mm-hmm.
And on an intraperitoneal abscess, you might be able to drain the abscess and it might be a bad anastomosis. You take that anastomosis down, you can easily put it back together and then make a determination whether or not you want to do a diverting proximal diversion or not, versus a lower anastomosis that isn't so often easy to be able to just take down. And so oftentimes in a stable patient, these are the ones where you want to be able to do an examiner anesthesia. Maybe the drain is a little bit different, but it's not so easy to redo that anastomosis. So we take those things into consideration.
Do you have a number you can put on the risk of extrasphincteric fistulas for these transgluteal drain placements?
Yeah, I would say to you that, it's not reported well in the literature. What you're hoping is the fact that you drain the pus away, you get that out, and essentially the cavity itself will collapse, everything will go down, and you won't have it. But certainly, I would tell you that they're probably a little bit more common than we say, whether you say, I always learned in residency when asked a question like this, you say, is it high, is it low, or is it somewhere in between? And if it's relatively low, it's, less than 15%. It's just not something that we write a whole lot about, but it is certainly something that has to cross your mind. And in my view and in our practice, a lot of times what we'll do is we'll do an EUA here. We want to directly look at that anastomosis, especially in a fresh post-op patient, and you might see a defect that's right at your anastomosis leading into this cavity that's kind of not really kind of having some leaking pus out, but it's building up because it's inflammatory. You can put a drain right through there and then get it to collapse. Okay, here's another case. So in this particular case, what we have is we have a 74-year-old female, and again, I'm just kind of adding things in there, that had a previous low anterior resection, and she had a diverting loop ileostomy. And Patrick, I'm just going to give it to you. This was actually her gastrographin enema at about a year. And you may say to yourself, oh my God, why is she getting a gastrographin enema at a year? I take my diverting loop ileostomies down either 6 weeks after their chemotherapy, or if they've had their chemotherapy up front and under the new protocol of having, the total neoadjuvant therapy on there, the TNT, that once they finish, they get their gastrographin enema and it's not there. And so I'm going to give you that they had a gastrograph, they got their chemotherapy for several months, they came back to you, got a gastrographin enema and it showed a sinus. So you decided to wait 3 more months, they got it again and it shows a sinus there. And now here we are, we're out at about a year. And all of a sudden now we take a look, and for our listeners out there, what you see is that at your anastomosis, you have that pesky 5-centimeter sinus that isn't going anywhere. It is just sitting there coming off of your gastrographin enema. And the patient's looking at you and they're like, I'm sick of this diverting loop ileostomy. Can I get rid of it? And then you take them to the operating room and just to do a quick examination or anesthesia, and you want to do a flexible sigmoidoscopy and take a view and see what's going on. And obviously in this case, you see a little bit of the gastrographin left over, but Patrick, walk me through.
Yeah, so on this images here, we got an endoscopic look at your anastomosis that shows the sinus tract pretty clearly in addition to the lumen. And I'm actually curious what you ended up doing with this patient, because it looks like you did a bit of an intervention here, but I can't quite tell.
Yeah, so let's talk about this in there. So, in the past, so now it's important to understand a lot of these things like leaks is that not everybody's the same. Is this a healthy 74-year-old? Are they not a healthy 74-year-old? Where exactly is this low anterior anastomosis? Is it truly a coloanal, or is it mid-rectum, or what are we dealing with? The sinus itself, as I talked to you about, we're quite a ways out, so we know that the patient is diverted and this sinus probably isn't collapsing. We were hoping that it would collapse on their own. And you have a couple of different options that are there. And so what we're trying to do with here in the picture and what he's saying is that it's more of a probing of that sinus, not necessarily intervening on that, but you do have a couple of different options here. So you want to get rid of the ostomy. So Patrick, walk me through a couple of the different options of what you could do.
Well, so you can stick with it a completely endoscopic approach and try things like different endoluminal devices, tissue sealants. You can do over the scope clipping techniques as ways to try to get this sinus to close down and continue to manage that in a minimally invasive approach that you can move forward, hopefully at some point with taking that diverting loop down.
Yeah, absolutely. And I think that let's just touch base on both of those as well. So, over the years, back when I trained, there was none of these different endoscopic views of what you can do. To be able to say, you have the bear clip or some of these other ones where you would, we've tried fiber and glue in the past to get these sinuses to heal in. A lot of those don't necessarily work. Throughout the time, we talk about opening that sinus up where you kind of basically are dividing, you'll see either with a stapler or a ligature, dividing that chronic tract since it's been so far out. You wouldn't do this in a fresh post-op, but you're a year out to kind of be able to incorporate that all into one. And depending on your anterior or posterior, is it in a woman, do you run the risk of having intraperitoneal entry? That a lot of these things need to come in place. It's probably a little bit more difficult in a 30 to 40-minute talk like we're putting on right now in these clinical situations. But what other things can you think of that might be able to do?
Well, and in the end, I think we could try these different approaches endoluminally, but ultimately going to have to probably redo this anastomosis, take down and redo would be the most definitive approach to her. I'm trying to think of anything else that might be a smart way to do it, but I think in the end, if you're a year out and this is persistent, you have a really tough time getting anything closed down. And then there's different, for instance, an endovac, which you could probably describe more detail than I can.
Yeah, absolutely. So, this has been tried probably more in Europe, and we don't have anything FDA approved. That's my disclaimer right now. I'm not telling you what it, but just for all of our viewers and our listeners out there, it is something that you might be able to read about in trying to use some of the negative pressure therapy to be able to fashion. I know they have had some commercial ones in the past to be able to go implant in the operating room, put in that cavity, and then get it to be able to shrink down. And kind of be able to go all the way away. And then redoing the anastomosis, not a fair trick. It really is something, not for the study of heart. In some patients, it can be very difficult, especially, if they've had prior radiation therapy, if they've had a difficult leak that might cause a lot of fibrosis in there. And to say, am I going to be able to get below it? Am I going to be able to do a colorectal anastomosis that's lower to the anal verge or coloanal? Or if it's really low and you're having these problems, is it something that you do a pull-through procedure as we talk about a Turnbull Boutte? And so you kind of hit the nail on the head with this. We talk about, and really this is the type of one that you got to think all the way through. And again, tailoring your decision-making process to the patient in front of you, because definitely not every LAR is the same. Not every patient is the same. And simple, a couple of heights, an 8-centimeter anastomosis versus a 2-centimeter anastomosis might completely change what you're going for. We've tried stents in the past. I know that This has been done in the upper GI. Colorectal with a low anastomosis, how are you going to put a stent in there? Is it going to migrate? Is it going to stay? Is the patient going to have a tenesmus the entire time? And that's really why the data isn't that great as of yet. They haven't really worked that into the equation, but you might see some case reports or some things, an example in there. But again, what we're trying to accomplish here is to basically show you that we really are thinking through these patients and the decision-making going into it. And here's just an example of the close-up of that dehiscence. And this is exactly for what Patrick was describing, that you can see the anastomosis, maybe a little bit narrowed, and then off to one side, there's a clear sinus that's going out. The anastomosis itself is broken down, but because they're diverted and because it's been a while, it's something that is just definitely not being able to heal all the way, and you can see it here.
So when it comes to those endoluminal approaches, there's lots of new stuff being talked about and new attempts being tried. And certain, centers such as Cleveland Clinic, maybe have more experience in those areas. Is there a take-home point for the standard general surgeon or acute care surgeon like myself that we can kind of keep in our back pocket to say these might be an option for my patient, especially one that might be one approach that may be more successful than the other?
Yeah, again, for some of the ones, it's all an anecdotal experience. You'll see some low rates out there. Some people are, they swear by these clips, these over the, Ovesco clips, or some of the other ones. There's other people that view very highly that you can, make a negative pressure therapy that will be able to go in. What I like to say, other people believe in open that area up. What I typically like to say is that you really have to take a look at the patient and see, where is that anastomosis? What can they tolerate? How clinically stable are they? Is it somebody that would be best served as a redo? Are they somebody that is best served with making a trial? And then I should say out there that there is some people that have had success with a year out in a very small sinus about having that discussion about just taking the ileostomy down and seeing how they do. And if the patient gets sick, you have that discussion with your patient and saying, listen, this might just be a sinus. You may be an asymptomatic sinus even as stool goes down. You've been out there a year, it's not changing, it's very small, and they'll just do fine with it. But if that you're approaching that part, I would make sure you have that discussion with the patient. Let them know there is a sinus there. There is a chance that they could get sick, form an abscess again, and they may have to go back and get read.
That was going to be my last question. Is can you pull that trigger, and when do you feel comfortable doing so?
Yeah, and I think that with a little bit more experience and time, you feel a little bit more comfortable with like that. So, don't forget about that option, but have that discussion with the patient. So now let's talk about this particular patient. So in this particular case, this is not somebody that has a leak, but this is somebody that we're going to talk into kind of preventing a leak. So 83-year-old male comes in with abdominal pain, oftentimes from a nursing home. And what you can see here on this particular sagittal imaging on the, or the coronal imaging on this is essentially that you have a volvulus. And now you're going to take them to the operating room. And what you see here is not uncommon. You see a very large distended colon that almost looks like somebody, blew it up with air, blew it up with a balloon. And then it starts looking on the rightmost picture a little bit dusky, and maybe even on the order of being gangrenous. So Patrick, nobody likes to have a stoma. You got an elderly patient. The rest of the bowel looks hand in hand. They're hemodynamically stable. How do you approach these? Is there something that you go into when you're going to say, we talked a little bit earlier about, your concept of, does a proximal diversion prevent a leak? How does this come into play when you're talking about something that's a colonic in origin?
Yeah, that's a great question. And we'll keep repeating the theme here, is this is patient specific too. So I want to know about this patient's comorbidities. I want to know about their clinical status before they come to the operating room, and any other risk factors for the development of anastomotic leak, many of which we talked about at the top of the show. And certainly any bowel that is compromised grossly, especially, and for certainly our viewers can see it, but the listeners, we have a change here, and the initial part of the operation to the latter part of the operation, in which Dr. Steele mentioned this very dusky bowel. That bowel has to go. That's dead bowel. That's coming out. There's no questions about it there. There's certainly different ways to assess for the viability of bowel beyond just looking at it too, which certainly includes putting your fingers on it and feeling for a pulse, getting a Doppler probe out, checking for that, getting your Woods lamp, fluorescein out, SPY technology, et cetera, to see what kind of blood supply you have to that bowel. In addition to that, in these kind of emergency, certainly in our world of emergency cases, you can have bowel that may be healthy, but is massively dilated. And you may only be able to work with that in to a certain extent, in which maybe it's too dilated to make a small bowel to large bowel anastomosis. Maybe it's frankly too dilated to create a safe ostomy, or an ostomy that'll serve the patient well. In those circumstances, you can also have to think about, does this bowel just need to go? Is this the best thing for the patient? Now, in terms of putting them back together again, we want to do that. I think you want to err on the side of putting folks back together if you have your risk benefit ratio kind of profile figured out and you think it's doable for them. And when you're on the edge there and say, well, I don't know if this is going to heal as well as I think, that's when you can reach for that diverting loop ileostomy. That diverting loop may not actually stop that bowel from healing, or may not allow that bowel to heal together better, but it will prevent stool from coming out of a breakdown if that happens, and allow that patient to not be as sick. And that's what we mentioned at the top of the show.
Yeah, and I think one of the things that's interesting is on left-sided leaks, the common question is that if I just divert them proximally with a diverting loop ileostomy and I still have a column of stool, is that appropriate? And there's not a whole lot of data on. There's a couple of series that would suggest that they do just as well.
Mm-hmm.
Being able to wash the patient out, lay some drains, and do a diverting loop ileostomy. For example, a colorectal anastomosis on the left side and doing a diverting loop if you have to take it. If you don't want to take that anastomosis down, again, we didn't get into it specifically, but you can kind of break leaks down in terms of, is it a pinhole opening? Is it fibrinous exudate? Is the thing blown apart more than 50% where there's no hope for that anastomosis? And these are the type of things that you got to be able to go to. But now we're looking at a picture of a really, really gangrenous bowel, gangrenous colon, and we're trying to be able to avoid that. And there's other factors to what you talk about. Are we dealing with associated injuries where somebody's hypotension? And so really, you hit it, the nail on the head when we talked about probably one of the most frustrating aspects is if I said to you to start out, I said, Patrick, why did anastomoses fail? You could list these things off right now: tension, ischemia, technical problems, obstruction, radiation, abscess, trauma, malnutrition. You've named them all out. But why is it that somebody where it went beautifully, and even everybody who was, if you had 15 people standing around that operating room and they said, Patrick, you literally just did the best anastomosis ever. You followed every principle to a T in a young, healthy patient, pulsatile blood flow, and then they leak. Why do anastomoses fail in that setting?
It's a great question. That's a great
It's
question.
a great
That was a
question
heavy.
with
I'm
no
blaming
answer.
on the gut microbiome. Dr. Alverdi's work is what I fall back on. No, it's a great question, and it is a frustrating one. And I think it goes back even to just the core principles of surgery, where you want to make the best anastomosis that you can. You want to do the best operation that you can. And so when it comes to, you make your anastomosis and you're looking at it and you may not be happy with the way it lays, the blood supply. If you have the opportunity to fix it, then you should fix it. Don't leave that operating room without giving the patient the best operation they can have. Because if it does leak, you want to know that you did everything possible. And there is, like you just said, we said at the top show, if you're operating and you're operating a lot, and especially in the acute care surgeon world, if you're operating, these things are going to happen. But you want to be assured that you've done the absolute best job that you can for the patient, so that you feel you and the patient can know that you did the best thing for them.
Yeah, amen. If this is something where you're hoping it's going to get better, that's the wrong way to look about it. So you talked a little about this before in the past. So walk me. This is for those of you at home. We're just taking a look and saying a lot of different things about where you're taking the vessel, if you need length or something like that, and how can we have, technology in this particular case, that's just ICG. Patrick, do you use ICG? Is this something that's a routine part? I know that in the colorectal world, there's been 3 trials of pillar 1, pillar 2, pillar 3, and it's not really kind of necessarily panned out, but there is some data that would suggest that it can alter and it can be helpful. What are your thoughts?
Yeah, I've used it very, very rarely, only in circumstances where we're in a hard spot where we really need to put that anastomosis needs to happen where it needs to happen. And I'm looking at the bowel saying I'm really not sure, and used that fluorescein and SPY type technology to tell me or make me feel better about going forward with the surgery or drastically altering that operation and potentially doing something like a permanent endostomy, but not regularly.
Yeah, and here's another a small video. So this talks a little bit about how we construct our anastomoses and how we're being able to make sure that we don't have potential areas that are ischemic. So here's a video here. So for those of you at home, we're doing a colorectal anastomosis. We try to get that kind of right angle to the bowel. Patrick, so in this particular case, what we're looking at here is we're looking at your classic dog ear. Walk me through this.
Yeah, so the video is showing us coming across with our linear staplers, which are just that, linear, right? And there's certain degree of a play you have with those staplers, but in the pelvis, it can be very challenging to get straight perpendicular across that bowel. And so, alluding to the fact that what I was saying earlier is we created a piece of bowel here that has this massive dog ear on it, and that is not an ideal for anastomosis. And so if the opportunity is available to fix it, we want to go ahead and do that. And this video is showing us a simple repeat resection of a centimeter or 2 down from the original staple line that mitigates, that removes that dog ear and mitigates the risk for anastomotic issues that I think would be very high, very high with that type of tissue bridge that you had left with that dog ear.
Yeah, and so again, for this is obviously in a robotic or a laparoscopic approach where many of the staplers can only go 45 degrees. It's very difficult sometimes to get a little bit of a longer stapler down there, like a 60, even in, especially in a bulky male pelvis where that's hard. And so you got to be able to say to yourself, if I have to fire more than one staple line, what's clear, there's the data out there is that, as you start to get into 3, 4, 5 staple lines and you're zigzagging down that rectum, that's going to increase your risk of leaving ischemic changes, crossing staple lines, and high risk of leak. So we want to make sure that if we, at all possible, we skeletonize that rectum, get on the back wall of that rectum, being able to, how do you pull on that rectum to get as much of a tangential to avoid those ischemic areas? And then if you do have to fire more than one stapler, to make sure you get it down where that kind of crotch area is to allow that to come across as much as possible to avoid an ischemic event is critically important. We talked a little bit about tension. I'm going to pose this question to you. Is this too much tension? So you, as we're looking on this video here, the staple line comes up. This is a Baker anastomosis. I'm going to ask you that question in a little bit, where it's an end to side. You go laparoscopically to bring down your left colon for this kind of following a sigmoid colectomy. As we start to grab it and we start to bring it down, like many things, it doesn't quite go on as well as you would like it to right off the bat. And all of a sudden it kind of falls back and starts to spring back like a slinky in the upper abdomen. Patrick, how much tension-free is too much tension-free? Because again, you can, as you see right here, you can get that connected to the anvil staple, you can bring it down. How do you gauge intraoperatively, specifically in a minimally invasive approach, how much tension is too much tension? Are you looking for, is it floppy? We all know that. And is it really, really tight on a bowstring? We know that. But what about that middle ground?
Yeah. And that's a tough question. That's in this case, what you were showing in this video is, again, that descending colon coming down for colonal or colorectal anastomosis, excuse me, and it's springing back. I think that's less than ideal. And if we have the opportunity to revisit our dissection and free up some of that colon so that it doesn't do that, then that's the first step. If you're at your maximum dissection and you've cleared as much as you can, then you may be between a rock and a hard place, and you have to use your best judgment and determine what feels right and what doesn't. And that's, I think, maybe different for every surgeon, and certainly folks with more experience may have a different take on that. But if able, I would want to free up that bowel a bit more.
Yeah, absolutely. And so the old context of saying, is your splenic flexure taken down? Have you really taken it down? Have you taken down those pancreatical-colic ligaments that are retroperitoneal? Where are you taking the IMV up by just lateral to the ligament of trites? All of those things come into play to make sure that you can get as much tension-free as possible. So now I'm going to pose this question to you. In the drawing on the right-hand side of the screen, you see that the stapler for a left-sided anastomosis, that end-to-end stapler, the spike is being brought out, in this case, just posterior to that transverse staple line, and it looks like your EA is going to incorporate that staple line. On the video, for those of you who saw it, that was something where you have a Baker anastomosis where you're having an end-to-side anastomosis, trying to keep that proper distance of a few centimeters so you don't have that ischemic segment. Patrick, how do you, if preferentially, where do you put your spike out? Are you a corner person? Are you a Baker person? Are you anterior? Are you posterior? Doesn't make a difference at all.
A dealer's choice. And we just had this conversation the other day with one of the residents about all the different options you have, and we actually wrote them out and we drew them out. And in the end, it's whatever you're comfortable with, and it may be whatever works best for that patient in that particular scenario. Because there is no, at least, proven difference in the literature that tells you one of these anastomoses are better than the other. And I've looking and experimenting with different approaches to try to figure out what I'm most satisfied with as well. And to be honest with you, I think it depends on, for me, the different patient and how that anatomy looks, and I'll use different techniques as needed.
Yeah, so I think that we hope to have an answer here for you. We've been running a little bit of a data collection on this particular one prospectively, and so we're about to get to several hundred patients being able to look at this. And so what I would tell you is that the most
you're not gonna tell us what
I am not
you
going
found?
to tell you right now until it gets published. But I would tell you this is that this is one of those things that I love about surgery, and I love about having small group talks about this, because in a setting of 10 to 20 surgeons, everybody does things a little bit differently, and they all swear by it because we're dogmatic in many ways, and trying to end that dogmatic approach and get a little bit more data. But there's certainly some things that we do know. Obviously, bringing that spike out in an area where essentially you would leave an ischemic segment. I mentioned it before, like in the Baker anastomosis, where you would have just a very small section between two crossing staple lines may make that ischemic. We want to avoid that, that's for sure. Having the ability to, if it's, if the vagina is close and you're putting it out the front end, you can get that vagina trapped in there. That's not a leak, but that's another complication that could occur where you may want to go posterior. So these are all the type of things that we want to keep in play. Now it's been a long day. We're sitting here this evening. I was in the OR today. You were in the OR today, and you're finishing up your last case and you're getting ready to go. And here's a video right here. I just want to know how you deal with this. You do your famous air leak test.
Lots of bubbles coming out.
Yeah, lots of bubbles. And in this particular video, this particular person decided, I'm going to oversew that. And so let's talk a little bit about that difficult situation, the donuts. So you either get an incomplete donut or kind of an eccentric donut, and then you get that air leak, and you feel a little bit better about yourself, and you say, oh, I'm going to retest it again after I repair that one. What is your approach to this scenario?
First and foremost is do the air leak test, right? It's a good thing to do. It's you want to test your anastomosis and see, and you have a couple of different options. You can certainly redo it. You can simply redo it. If you have a lot of available bowel to work with, that may be your best bet. Number two is you can repair it. And especially if it's if you're satisfied with the rest of what you've done and the way things look, and you have good access to things, you can definitely oversew that staple line to the point where you essentially make your own sutured anastomosis, and certainly can retest. And if that appears satisfactory to you, that's something that may make sense to keep as well. And do we have any more video on is that the follow-up test where we were leak free?
Yeah, that's the follow-up one.
Great.
In this particular case, I believe that this particular person got a diverting loop ileostomy. But again, I think that, when we talk about intraoperative leak testing, how often does it occur? And I encourage everybody, I put the reference down here right now in terms of Rocco-Ricciardi's, and you said it best. This is something that should be standard, that you're testing your left-sided anastomoses, that you are making sure that, you're doing that air leak test. And you can see in this available here, a leak test positivity can be all over the map, and hopefully it's a lot lower than that as this time goes on. This paper is obviously 10 years old now, but it's an oldie but a goodie. And one of the important things that we know is that exactly what you said, is that it decreases both a clinical and a radiographic leak rates 2 to 3-fold.
Yeah, and I think one thing you mentioned that folks may not think about is you said left-sided, right? So it's not just your anastomosis that sits deep down in the pelvis. Those left-sided anastomoses can be checked, can be easy, just the same way you do it. It can be checked just like you do your coloanal anastomosis to your colorectal anastomosis.
Yeah, absolutely. And so, and we do know, and again, we're not going to go into that one single paper, but we do know that, probably the lowest leak rate is associated with redoing it. And that may be easy if it's a sigmoidectomy and you got the anastomosis right there and you can do. It's a different story if it's mid-rectum. You may not be able to do that. Probably second is to be able to repair it or proximally divert it. But either way, to ignore it is unacceptable. And understand that just by repairing it alone, and I think in that particular paper had about an 8% leak rate. Don't exactly quote me, it's been a little while on that, but it's been around that type of one. So I want to just end here with this kind of difficult clinical scenario, and we're just going to go over a few and quick things that I think are critically important. And Patrick, I'm going to have you walk through some of these things.
Yeah, number one. So you want to know about the clinical condition of the patient. We talked about that. That drives your decision making. If the patient's sick, if they're septic, you don't have a choice. It doesn't matter if it's 14 days and you're worried about adhesions and how stuck the thing's going to be. That patient needs to be explored, and they need to be diverted. They can have a resection of that anastomosis and redo with diversion. They can have resection and just straight diversion, but they need to be addressed in the operating room. We talked about abscesses. Certainly, if it's any larger than 3 centimeters, we want to get that drained if at all possible, as a primary way to for source control, and treat with antibiotics and monitor that patient for improvement. And last, if you don't even have, if someone comes in and they don't even have a frank abscess that can be drained, we're going to watch that patient keep them NPO for a bit, give some IV antibiotics, watch, wait, and see if they declare themselves, if they're at the beginning of that process of getting sicker, or if they're going to maintain that stability for you and recover without any major interventions.
Yeah, and when we talk about it before, we let off this thing by saying all leaks are not the same, and a lot of it is based on location. So hopefully, these are the type of things that we think about when we go through, colonic leaks. We think about, is it right-sided? Is it left-sided? Are they stable? And we do conservative management. Do you have enough, that we're dealing with colon? So can you take this down and re-resect? How is your blood supply to that patient? You can divert the patient, as we talked about before, especially with a lot of risk factors in a clinically unstable patient. But understand, just saying, I'm going to do a stoma every time, understand that in many of these cases, in the literature would suggest that, and depending on your patient demographic, a permanent stoma may be a pretty high thing that they never get it taken down for. And so really understand that. In that mortality in many cases, and this might be the fact that some of the rectal leaks are walled off, mortality leaks associated with the colon are reported to be higher than the rectum. And we end with this picture and to talk a little bit more about the fact that, all leaks are not the same. It can be absolutely devastating. You get in there, you see this fibrinous exudate that's shown by this particular patient. It makes your heart drop. You know that you're there for a reason. You're trying your best for that particular patient. But Patrick, you said it best earlier, is that if you think at the time of the primary operation and you notice a problem and you think it's going to get better, on its own, and you have some doubt, that is not the time to be able to say, oh, it'll probably do fine. We need to be addressing that point. So final words, my buddy.
No, I think that's an excellent review from someone who's done an awful lot of colon and rectal surgery. And again, be happy with your final product, and know that operating leads to leaks. There are going to have some leaks, and today I hope we helped you through the management a bit and understanding that not all leaks are created equal. You have a lot of different options to consider when approaching these patients.
And so with that, dominate the day.